very stimulating, excellent meeting. It's my challenge today to talk about an operation that is threatened to sort of fall behind more modern developments, and I hope I will be able to give a balanced view of its pros and cons. Unfortunately, I was not able to be here this morning when Professor Alexi talked about the history, but I'm sure that he did not forget to mention Giancarlo Rastelli's achievements by conceiving this operations. Theoretically, he was never allowed to operate in the US at the Mayo Clinic where he was as a research fellow, but Dr. Wallace then performed this operation in July. I think 69 is not correct, 68 I think it was. And so that was truly a milestone because it for the first time enabled surgeons to put the true left ventricle in the systemic circulation in children with complete transposition of the great arteries. This here is an image taken from Rastelli's initial publication in the Mayo Clinic Proceedings on an autopsy heart. There you can see how he conceived and prepared the concept. The concept itself, I guess, is familiar to all of you. We are mainly talking about patients with transposition, VSD, and subpulmonary stenosis, which is synonymous with left ventricular outflow tract stenosis in the setting of transposition. So this is what we have here. And his idea was to close the VSD in a fashion that the left ventricle then will be able to empty into the aorta, divide the pulmonary trunk here, and then implant a conduit from the right ventricle to the pulmonary arteries to restore pulmonary blood flow and thereby putting the circulations in series in the physiologic fashion. This here is another of the original depiction then of the second article that they published after they had operated for the first time successfully. And this is how they depicted the various key stages of the operation. Nothing much has changed since then, and I will take you through the details of the various steps in a second. Before we get there, let's talk about the basics. As I've mentioned before, this operation was initially developed for complete transposition with VSD and left ventricular outflow tract stenosis and for nothing else. Of course, over time, the term Rastelli surgery has been applied to other surgeries, other operations for other malformations as well. Some people use it in a very liberal fashion and call everything that includes VSD closure and implantation of an RV2PA conduit a Rastelli type operation. This is not according to the original concept, but still it doesn't really matter. Congenitally corrected transposition, again with VSD and LVOTO, is also something that is very close to being a typical Rastelli operation. If you choose to do it, however, then you combine it with an atrial rerouting at the same time. But similar operations are essentially what we also do for truncus arteriosus, PAVSD, and various forms of double altered right ventricle. There are alternatives to these operations, to the Rastelli operation. They are listed here. Some of them are of historic importance, such as Megoon's interventricular repair or Mustard and Sanning alone for complete transposition. And this here in the middle is sort of the current stage of surgeries that is available nowadays to children with complete transposition PSD, VSD, and LVOTO, and I will talk about that in a second too. I took these beautiful images here from Karl Backer's publication in Operative Techniques of Thoracic Cardiovascular Surgery. They give a very detailed overview. I can highly recommend it to anybody who is interested in this operation. You see here that in this child here, a shunt had been placed beforehand. This is what we would still do in many of the children nowadays, enabling us to operate on these children ideally when they're 1.5 years old or 2 years old. But many of the children that are or have been actually operated on by the Rastelli operation have been substantially older. The child is then placed on extracorporeal circulation. The shunt has been divided, the aorta is clamped, a vent is inserted, and then the fun starts. The first critical step is you open the right ventricular outflow tract. However, this is not in the true position of the normal pulmonary valve, because where the pulmonary valve would be or should be, the aorta is, and it stays there. So this is the location where the conduit will originate from, and this is not orthotopic. This is not where it normally is. It's a heterotopic implantation, and this has some important implications for outcome. It's not enough to simply incise it, trying not to ruin any major coronary arteries, but then you should also excise any excessive muscle that is within the field of incision, so that you have unobstructed inflow then into the conduit when the time comes. Then you visualize the VSD, which is usually easily done through this rather large ventriculotomy. And I will also get into the details a little later. The VSD can be enlarged if it seems to be too small, as a rule of thumb, as with any patient in related operations. The circumference, the diameter of the VSD should be identical to that of the aorta, if not a little larger. So if it's not as big as the aortic valve, then you enlarge it. I will tell you later how exactly you do this. Once the VSD has been enlarged, you close the VSD by implanting a baffle, a patch, either a true patch material or a vascular prosthesis, which is already in a tubular fashion that you can open, that gives the whole thing a more natural rounded configuration. You implant this patch, you go here around the base of the defect here, the apical basis of the defect. This is where you are in the vicinity of the VSD. Oops, sorry. But then, more towards the head, the sutures go around anterior to the aorta, to the aortic valve. And thereby, blood flow then, once the baffle, once the patch is in place, is guided through the VSD from the left ventricle into the aorta. This here shows you interrupted sutures. Some people prefer to do it with the running sutures, and some even use combinations of both interrupted and running sutures. Once the VSD has been closed, you divide the main pulmonary artery, you oversew the stump. What people usually recommend is that you take the leaflets of the pulmonary valve into the sutures so that you don't create a blind space between the suture and the leaflet, which would inevitably thrombose and may be a cause for embolism. So you divide the pulmonary trunk, you suture it close, and you use this opening here then for implantation of the conduit between the right ventricle and the pulmonary arteries. About the choice of conduit, I will also make a comment in a second. Well, and that's about it. Then you're finished, you go off bypass, and everything is fine, at least theoretically now. The systemic circulation is supported by the left ventricle, and the pulmonary circulation is supported by the right ventricle, as it's supposed to be. Here is already, this is taken from the original publication by Rastelli and Wallace themselves. This already shows you an important difference, an important modification. They originally suggested to place the conduit to the right of the aorta. Yeah? Whereas here in this more current depiction, nowadays most of the surgeons would place the conduit to the left of the aorta. If you do this in the original way, the conduit will be squeezed between the sternum and the aorta. It may be narrowed, it may be obstructed, and next time you have to get in to replace the conduit, you will have problems trying not to open it when you saw into the sternum. So this is the main reason why nowadays we would always implant the conduit to the left of the aorta. Okay, this is the concept of the operation. It does have significant problems. The key problems, the issues that everybody talks about, is obviously failure of the conduit from the right ventricle to the pulmonary artery. The second key feature, key problem is left ventricular outflow tract obstruction. I will show you in a second why that is so important. And the third is AV block, which is also induced inevitably or not, at least it happens in a relevant percentage of patients who have undergone the Rastelli operation. There's a number of other problems that occur with not such a high frequency, but they have also been described repeatedly If you have a leak in the baffle that you have implanted, then you will have a residual VSD. LV function impairment then maybe as a consequence of a chronic left ventricular outflow tract obstruction, reduced right ventricular function due to the ventriculotomy and also due to volume loss, because the right ventricle becomes the more generous the baffle is you implant from the VSD to the aorta, the more you take away from the volume of the right ventricle. Tachyarrhythmia and sudden death is also a problem in the long term after Rastelli operation, and pulmonary hypertension has also been described. So let's talk a bit about conduit failure. I think it's clear to everybody in the room that there is no perfect conduit yet. We here at the Heart Center would choose a Concheca bovine conduit for small children as soon as the size allows it. We would go for cryopreserved homografts. Other groups prefer commercially available porcine valve conduits or non-valved conduits, artificial conduits with no valve in them when the child is very small. Decellularized alloxenografts have also been recently developed and been used in this concept. And as you all know, we are still waiting for these tissue engineering grafts to actually come into existence and to work. These conduits, no matter which one you choose, they will inevitably fail. They will either become stenotic or they will become dilated and regurgitant, and this is just one example of a severely calcified homograft after a couple of years. So, conduit failure has been taken care of. Now let's quickly talk about left ventricular outflow tract obstruction. This is an anatomic specimen taken from Mark Hasekam's paper. This shows you the right ventricle in a child with complete transposition and VSD, and on the other side, in the left ventricle, you would be able to see pulmonary stenosis. This is the VSD, here is the aorta. Here are the insertions of the tricuspid valve. So you have to place your patch, you have to place your baffle around the VSD and then up here, up here, and then anteriorly around the aorta. And you can already see that the distance is quite long. It varies in length, but it generally is quite long. These defects are not automatically clearly subaortic. And there is, for instance, tricuspid tissue that you interfere with. And there is the outlet septum here, which can be very prominent and also cause obstruction. So there are numerous potential factors that contribute to the development of left ventricular outflow tract obstruction after Rastelli repair. And then there's obviously the tendency of a VSD to become smaller with growth of the child itself. This paper I found last night when I prepared this talk. It shows the first. What's wrong with it? Did I make a mistake? Ah, that's why, okay. So this is actually the first publication of the typical problem left ventricular outflow tract obstruction after the Rastelli operation. It was published in '76, so 7 or 8 years after the first operation of that kind by the Children's Hospital Boston group, and by angiography they nicely show the typical left ventricular outflow tract obstruction after Rastelli operation. Here would be the VSD, it becomes smaller, and hence there is LVOTO. In more modern times we use echo. This here shows you a representative echo image of the same situation, and it also shows the kinking of the outflow tract. This is the orientation of the ascending aorta, here the aortic root. This is the long axis of the left ventricle, and you can see here that the outflow has essentially to go around the corner to go into the aorta. For comparison here, this looks like a normal heart. It is not. It is also a heart with transposition, VSD and PS, but this was operated on using a more modern surgery that Dr. Hübler will later tell you everything about. Another example of left ventricular outflow tract obstruction is not only the width of the defect of the VSD that poses a risk, it's also the length of the buffer that you have to create, of the pathway that you have to create, which correlates with the development of left ventricular outflow tract obstruction. And this group here suggested to measure this beforehand and determine whether patients are eligible for the Rastelli operation at all. And they divided their cases in some which have a very long distance between the aortic valve and the crest of the VSD, and some which have not such a long distance. And outcome after the Rastelli operation was much poorer in those with a very long new outflow tract. So when the VSD tends to be small, we should make it bigger. We should enlarge the VSD whenever we feel that the VSD will not be large enough or will end up becoming too small in the future. This is not as simple as it seems. This here is taken from the originators group, from the Mayo Clinic, from their publication from 2001. This is what they suggest. You go anterior superiorly here towards the free wall, and you also resect at least part of the outlet septum. Whenever you try to incise inferior posteriorly, you will produce inevitably AV block, because this here is where the conduction system is, since most of the defects are perimembranous by nature. So these are the original proposed excisions. There are some groups that advocate that one should do this more aggressively. Here they show an excision that is very large and also goes a bit posteriorly here. If you do this, well, you get a nice large VSD and you eliminate any risk of outflow tract obstruction, but you can also damage the heart. And this group here from Iran nicely showed that with aggressive enlargement of the VSD in the Rastelli operation, outcome is actually worse in terms of survival than in patients who had no enlargement. So if you make it too big, you get in trouble too. Another factor that contributes to left ventricular outflow tract obstruction is the insertion of papillary muscles. This again is taken from the Mayo Group's papers. They studied all their anatomic specimens and also their clinical cases and depicted the distribution of the insertion of the medial papillary muscle chordae tendineae of the tricuspid valve along the edge of the VSD. And you see here that in many cases it's up here. So when it's up here, you somehow have to get this out of your pathway, right? Because your buffle goes from here all around here. Yeah? So you have to find a way to get these chordae tendineae, these insertions of the tricuspid valve, out of your buffle. You can try to shape your buffle so that it goes around the insertions, if that's possible. However, if it's not possible, if they insert right beneath the aortic valve, you may have to excise them, take them off, and later re-implant them again after you have implanted the VSD patch. So, how good is this operation? Let's talk about the result quickly. This again is the original Mayo Clinic publication, 160 patients with long-term follow-up. This is survival here after 20 years. It's less than 70%, and this is freedom from reoperation. Clearly, just by the fact that they all have a conduit, they sooner or later have to undergo reoperation. What they also nicely pointed out is that the type of conduit, well, can influence the time you have to reoperation, but it doesn't really eliminate it. And regarding age, well, the larger a patient is at the time of operation, the larger the conduit is you can put in, and the longer he will not have to be operated on. That's self-evident. This is a similar publication published a year before in 2000 by the Boston group. Here this is 100 patients with also quite long-term follow-up. Survival, again, did not depend on the era. This is in fact an operation that they could do in the 70s and the 80s already with quite good early results. And nowadays we would expect to have no surgical mortality. In the old days, they may have had 1, 2, 3, 4, 5% early mortality, but not that much, by no means comparable to the early days of the arterial switch operation. So survival is not ideal, but one may call it satisfactory. However, again, freedom from reoperation. Here, stratified for reoperation for RVOT, for conduit failure, is very unsatisfactory, and there's also a significant proportion of patients who have to go re-intervention for secondary late left ventricular outflow tract obstruction. The Munich group also published a very nice overview of, I think, 70 patients who underwent the Rastelli operation for TGA in their center. Again, here they found a 20-year survival of only 58%, so these patients do die, many of them in the long run. They also found that survival is better when you do the operation at younger age here. Of the less than 4-year-old children, survival was very good. Of the older children, survival was not good. However, the younger the child is, the earlier you will have to reoperate. This again simply mirrors the size of the conduit. A very recent study published by John Brown from Indiana. Here he published extremely good results. He lost only 1 or 2 patients rather early and then nobody anymore in the long run. These are the best results of the Rastelli operation for TGA that have been published so far. He also has, of course, a reoperation curve due to conduit failure, but this is acceptable. And this is our experience here in Berlin. We essentially see what everybody else has seen. Many of the patients, the majority of the patients, will have to go a reoperation for conduit change, and some of them even have AV block. So what are the alternatives? Are there alternatives? I took the liberty to copy this image here from Dr. Predra's paper, which he published in 2001. I hope you will recognize it. It's in the 80s, a modification, if you will, of this procedure was proposed by Lecomte and ever since done extensively in France and elsewhere too. They call it the, I don't even try to say it, my French is horrible, the REV procedure, Réparation à l'étage ventriculaire. Is that correct? Thank you. They propose extensive excision of the outlet septum. I never really understood how that differs from an extensive enlargement of the VSD in a normal Rastelli operation. Maybe you can help me with that later. And one other key feature is that they don't implant a conduit between right ventricle and pulmonary artery. What they do when they do this procedure is they perform a direct anastomosis between the backside of the pulmonary artery and the right ventricular outflow tract, and the defect anteriorly is closed by a patch that usually contains a monocusp. There is a modification where they implant in between a ring of autologous aortic tissue, but I read somewhere that these in the long run seem to calcify and may pose more problems than they actually help. So here you don't have a conduit, hence you don't have a risk for late obstruction, but clearly you have a risk of regurgitation. These monocusps will never be completely free from regurgitation, but they argue that regurgitation then is better tolerated than residual or recurrent stenosis. There is a very curious, interesting, and sometimes amusing discussion going on between the Lecomte favorites and the ones who favor the classic Rastelli operation, namely Lecomte and the Boston group. And even independent groups here, one group from Korea showed that yes, indeed, the Lecomte operation results in lower a need for reoperation than the classic Rastelli operation, mainly due to the lack of a conduit, at least for the first here 10 or 15 years. The other alternative, the most recent one, the hottest one, is what Dr. Hübler is going to talk about a little later, modifications of the Nikaido operation, which has also been around for more than 30 years, but only now started to take up momentum. There are a few actual comparative studies who compare various trials. Ye and colleagues from the Heart Center, including Dr. Nikaido, who developed the concept himself, compared the results of various groups and various surgeons for surgery, for TGA, VSD, and PS. Here, Rastelli, a lot of reoperation, a lot of, this is actually survival, a lot of late deaths. The Lecomte operation, a little better, and the Nikaido operation, aortic translocation, and so on, with no late mortality. So this is another paper that I found from Fuwai Hospital in China. They also published a comparison. They have no long-term follow-up, and no patients died in the long run. So long-term outcome so far is good, whether you do Nikaido or Lecomte or Rastelli. But what this shows you nicely here is bypass time and cross-clamp time here. Bypass time 342 minutes for Nikaido operation compared with 170 minutes for Rastelli. That already shows you that the Rastelli is a rather is an operation. I wouldn't call it a simple operation, but it can be done within the means of your average pediatric cardiac surgeon, whereas a Nikaido operation is something that is clearly more challenging and much more time-consuming. The EACTS group published a multi-center study dealing essentially with everything that surgery-wise we have available for treatment of TGA with VSD and pulmonary stenosis, including the arterial switch operation alone or the arterial switch operation with a resection of the subpulmonary outflow tract, and aortic translocation and also Rastelli operations. Well, it's to some extent comparing apples with pears, because if you look at this here, you can clearly see that only very few patients that ended up having just a switch did have multi-level LVOTO, but the majority of the patients who ended up having aortic translocation or Rastelli did indeed have multi-level LVOTO. So these patients here who were allocated to the switch operation obviously had less pulmonary stenosis than the ones who had to undergo the other types of surgeries. This is also reflected by the Z-scores. Again, here there is a significant incidence of need for reoperation in the Rastelli patients. Survival, well, again, you have this late mortality here for Rastellis. You have some early mortality for switch operation alone. This may be actually due to not ideal patient selection, and you have very good survival for REF and for Nikaido procedure and its siblings. This is, again, freedom from reoperation for right ventricular outflow tract obstruction. Clearly, Rastelli patients need conduit replacements, the others don't. So, I'm getting to the end now. Essentially, the difference between these operations is whether you achieve an anatomic correction or not. This is the setting before surgery, TGA, aorta coming from the right ventricle, pulmonary coming from the left ventricle, with VSD and pulmonary stenosis. After a more modern type of operation, such as the Nikaido, and Dr. Huber is going to tell you everything about them, you end up with a nearly normal anatomic configuration of the heart. After the Rastelli operation, and to some extent also after the Lecomte operation, the REF procedure, you have a normal physiology, but clearly not normal anatomy. You have this distorted, kinked left ventricular outflow tract, and you have this clearly abnormal connection between the right ventricle and the pulmonary artery, and this is what ultimately limits your long-term results. So I would like to conclude that surgery for TGA, VSD, and PS remains challenging. It has always been and remains, and certainly will remain for the future. The Rastelli operation did indeed help save the lives of thousands of children, and it can be performed with very low early mortality. In fact, we expect to be able to do this nowadays with no early mortality whatsoever. However, it's clearly palliative. The conduit needs to be replaced, and the left ventricular outflow tract is a constant source of concern in all these patients, and more modern techniques result in better anatomic correction, but long-term results of those remain to be determined. With this, I would like to thank you, and the year is still very young, and this is why I put my New Year's resolution up there.